Okay, well, kia ora koutou. My name's Anita Gibbs, and we together are hosting the Social Work Perspectives on FASD APSAD webinar this afternoon. And I've got two lovely colleagues with me who will introduce themselves, but basically Joanna Chu and Karleen Dove. So what we're going to do initially was we'll do some acknowledgements and a karakia, and then each of us will talk for maybe 10 to 15 minutes. If you have questions, we'll encourage you to put them in the Q&A, and we hope we can answer those towards the end of our webinar today. So first of all, I'd like to acknowledge and pay respect to the past, present and future traditional custodians and elders of this nation, Australia, and the continuation of cultural, spiritual and educational practices of Aboriginal and Torres Strait Islander peoples. I'd also like to say a New Zealand Māori te reo karakia, eo ki te rangi, eo ki te whenua, eo ki ngā mea katoa, Ti hei Māori ora. Peace and thanks to our Sky Father, peace and thanks to our Earth Mother, peace and thanks to all precious things in between. Let there be life. So basically, as I've said, I'm Anita. I'll be talking a wee bit later, building on what my two colleagues have shared. Joanna will begin to look at sort of knowledge and attitude gaps and research around social work professionals. Karleen will carry on in terms of practice. What are some of the key issues for social workers when helping families where FASD is identified? And as I say, I'll try to draw together some of the kind of key themes and ideas and views of caregivers as well, in terms of how, from a social work perspective, we can provide, good practice and good evidence. So we will say over to Joanna.
Thank you. And I'm just going to share my screen now. So thank you very much, Anita, for the introduction. So I'm Joanna, and I'm a research fellow at the National Institute for Health Innovation at the School of Population Health at the University of Auckland. So as Anita has said, I am going to be talking about some of the work that we have been doing in New Zealand. I'm going to first off start with talking just very briefly about the New Zealand context in FASD, and then sort of moving on to what we've done in terms of knowledge, attitudes and practice in New Zealand. Not sure why, but not letting me move. Oh, there we go. So what do we know or not know about FASD in New Zealand? So we don't actually have a prevalence study in New Zealand, but given New Zealand drinking culture, we know that it's likely going to be a significant public health problem. Growing Up New Zealand data, which is one of our longitudinal study, which follows around 6,000 children and their families since 2009, has shown that around 71% of women reported drinking before pregnancy or becoming aware of their pregnancy, 23% during first trimester, and then 13% continues to drink after the first trimester. The Ministry of Health in New Zealand estimate that around 3 to 5% live births are affected by alcohol. And this is likely more common than autism and also Down syndrome. And we also know from evidence from Canada and Australia that suggests that around 10 to 36% of prisoners are affected by FASD. And so within the New Zealand system, it is likely to be overrepresented yet under-detected in our prison population. And it also disproportionately impact on our Māori, where Māori make up around 52.7% of the prison population in New Zealand. And this is the estimated annual cost, which is quite dated actually, back in 2016. So obviously the cost is going to be much higher now. And so we do have an action plan in New Zealand set up by the Ministry of Health in 2016, which was an approach to taking action on fetal alcohol spectrum disorder. But then, however, despite the sort of well-planned intention, it was very under-resourced and underfunded. And so, as you can see, in 2021, the Human Rights Commission and the Children's Commissioner released a report on fetal alcohol spectrum disorder, a call to action where basically saying that, you know, it continues to be under research and that successive governments have fallen short in their obligations to both the treaty and also the international human rights commitments and to those with FASD and the families in whānau. So unlike sort of other countries where perhaps they are more support for people with FASD, in New Zealand we are very under-resourced. So that just gives a bit of a background to what FASD in New Zealand is. In terms of the research that we've been conducting at the University of Auckland, one of the things that we wanted to look at was sort of around workforce capacity and how can we build more capacity around our workforce. So one of the things that we wanted to know was actually what do people know about FASD. We conducted a systematic review on FASD survey across sectors. And what we actually found was that most of the surveys were conducted with healthcare professionals, and we found only 4 studies internationally that have included professionals from the social and community sector, and also mainly conducted in the US or UK. And there were even fewer in New Zealand, where there was only 1 survey that was conducted with healthcare professionals, and that was done back almost actually more than a decade ago now, where at that time around 1/3 of participants self-identified as sufficiently aware of FASD. We also have a number of qualitative studies that have reported from various professionals working in justice, health and education, but again highlighting the lack of support, the lack of training and understanding regarding FASD in the New Zealand context. And so further to that, what we conducted was a couple of surveys and a couple of knowledge, attitudes and practice surveys with various sectors. So we've done one with the educators, we've conducted one on social workers or mental health workers, which I'll be talking more in detail today. We've also conducted one around lawyers and judges, and we're currently recruiting for healthcare professionals. So I should have included the survey link, but I forgot to do that, but I will do so later on. But we'll be really appreciate if that can be distributed. And I actually forgot to start off acknowledging all the participants that participated in our surveys and all the participants that participated in our research. I also want to sort of acknowledge everyone that has been on the research team as well. And so in terms of the social and community worker survey that we did, we had around 187 participants that participated or responded. As you can see, we had quite a range because we did open the survey quite broadly, and we invited everyone that considered themselves as a frontline worker working in the social or community sector to participate. And as you can see, there's quite a range, sort of from social workers to mental health workers, community support workers, youth workers. Others sort of included also people from corrections, people that considered themselves and working in the social and community sector. Most participants identify themselves as female. And in terms of ethnicity, we do have quite a good sort of represented range with 71% European, around almost 20% Maori, Pacific, and also 8% Asian. And most of them had worked in the sector for at least 5 or more years. In the survey, our survey respondents, over half of them reported only having a very basic understanding of FASD. Majority of them underestimated the prevalence of FASD in New Zealand, and around 20% believed that a diagnosis of FASD would not improve outcomes of those affected by FASD. Almost 30% believe that most birth mothers who drink when pregnant know it can harm the baby. Again, this really points to still the stigma around prenatal alcohol exposure and drinking. Almost 2/3 believe that diagnosis of FASD might lead to a child or their family being stigmatized. We also found that nearly half of the participants incorrectly believe that a distinctive facial features is needed or is required for FASD, but in reality, we know that the facial distinctive features only appears in less than 10% of those across the spectrum. 3/4 reported FASD to be relevant or highly relevant to their work, and 66% reported that 10% or more of their client may have FASD, with around 10% reporting 60% of them having someone with FASD. So again, very relevant to their workplace. A majority indicated that they would change their practice or behaviour if someone in their care was known to have FASD or suspected to have FASD. And it really showed that social workers who participated in the survey recognised different needs and required different approach, such as the use of different communication strategies and the need for different kind of support, such as advocating on behalf of the client, educating the individual's community, and support for the family. And when we asked about their support or how they were supported, more than 2/3 of participants reported having a client actually diagnosed or undiagnosed but suspected of FASD. And when we asked them what type of care or support was provided to these clients, you can see that around 27 of them actually noted very little or no support provided, or the support was provided on the basis of a different diagnosis not related to FASD, but for example, based on intellectual disability or autism spectrum disorder or developmental delayed. And they also reported they received very little or minimal information to actually help them support the client. And only 5% of our respondents felt very prepared to support someone with FASD, and 10% felt not at all prepared. And I guess some of these quotes from our respondents really sum it up. My team don't know much about FASD, let alone how to work with people who have FASD, and this is a huge challenge. Short-term interventions is not suited for those with FASD and their families. Being labeled as bad rather than struggling with FASD is something that's very common. And I think this isn't new, and I guess this really reinforces, what the international literature across a lot of various professionals across various sectors is, some of the barriers and challenges, again, is the lack of knowledge and skills, the lack of time and opportunities for FASD training. A lot of them reported actually not having complete information about their clients, so not having that full understanding or that full holistic picture, the lack of support from the management or other professionals to address FASD, lack of funding or services, and also the stigma around FASD. We also asked them what would actually help them to prepare social and community workers to better support people with FASD. Well, they all sort of mentioned the need for more training in general, ongoing training to update people on best practice and quick reference resources. It was very important for a lot of the social workers to actually have that meaningful engagement with Māori as well. Information on understanding FASD, so the strategies for engaging with people with FASD and managing the behaviour, support pathways, so actually access to funding for a diagnosis, what service is appropriate, and where to actually direct families if they do have FASD. We also found that only around 1/3 have had any training related to FASD or neurodiversity in the last 5 years. And again, continuing on, they sort of said these are some of the needs that we really want, or some of the training is perhaps having expert advisors on the team on FASD and peer support networks to help us better support people, information specific to the client, such as more detailed medical history, information from previous service assessment and recommendations, behavioural plans, along with coordination across service. And I think that sort of came up a lot in terms of the coordination across service, not having to have missing pieces everywhere and having to explain, to all these different people at each different step. The need for greater access to funding, such as disability support services. And one of the things is having the recognition of FASD as a disability. So I guess that's a really sort of overview of what we sort of found from our social worker survey. In terms of what they were open to training, I think a lot of people were just wanted any sort of training. So they were open to training workshops, online resources, FASD-informed strategies, protocols to support people with FASD. So there was a huge need in terms of training, and a lot of our respondents were aware of that, and they were really open to, what is out there to support them. So I guess, again, this really just sums up what we've been doing at the University of Auckland. And I know I sort of halfway through started acknowledging people, but I do want to formally acknowledge our funders for the project, also our research team, and all the participants that have participated in our survey. So now I think I'll pass it on to Karleen and for her to talk. Okay, I'll stop sharing.
I'll just say thanks on behalf of everybody, Joanna, for unpacking some of the stuff and good work that you're doing, because there's lots and lots of surveys, and it's really good that you're being so broad and wide ranging in the reach. So it is great to include a lot of those people who are working in the field, but may not pop up as the right label, because they're able to answer the questions. They're working in the field and they're sharing their knowledge. So thank you very much. And yeah, I hope we get some questions later about where we can take this, but really good stuff. Thank you. Karleen, how are you going? Have you got your share? Yes, you have. Ready to go. Okay.
Yeah. Ko Talanaki Tamonga, ko Makatawa Tiawa, ko Fritz Reuter Tuwaka, ko Dadinsky Raroa, ko Dove Uku Matua, ko Karleen Dove Norera Tinakoto Katoa. Hello, my name is Karleen Dove and I'm a registered social worker and counsellor. I have worked extensively in child protection, youth justice, addiction and sexual harm services in Australia since 1999 and back in New Zealand now since 2018. I'm currently a social work supervisor for Oranga Tamariki, and whilst Oranga Tamariki support my speech today in this role in this webinar, my comments are around funding and policies are actually based on my own opinions. I have recently completed a postgraduate certificate in the clinical diagnosis of fetal alcohol spectrum disorder via the University of Western Australia. So I'd love to see some training like that in New Zealand. So my first slide is around the stages of development. So alcohol can have a devastating and profound effects on the developing embryo and fetus during gestation, including cognitive and behavioural issues, causing permanent harms throughout the lifespan. There are far-reaching humanitarian and ethical implications, particularly in Māori children struggling with the ongoing ripple effects of colonisation. In 2019, the New Zealand Children's Commissioner, Andrew Beecroft, claimed that New Zealand will look back in 50 years' time with shame that we knew so much about FASD, but we're doing little to address that. With current and global research highlighting the plight of people struggling with FASD, one wonders why our government is delaying addressing this burning issue, particularly when research tells us the average lifespan of someone with FASD has been recently reduced to 34 years old, and that is Canadian research. In my current role, we assess the safety and well-being of children and address child protection concerns, usually via whānau-led hui, empowering whānau to make decisions for themselves. At times, though, we take matters to family group conferences, and sometimes on rare occasions, we take matters to court. So FASD is never the primary reason that a matter is reported to child protection agencies. Mostly it's hidden within the violence, addiction and mental health cases, and it takes a trained eye to spot the issue. Neurological worries are usually identified when a child is struggling with emotional, social and developmental delays. With the consent of a parent or a carer, though, we can refer children for a gateway medical assessment, which is completed by a paediatrician and a psychologist. When prenatal alcohol exposure is identified, along with confirmed developmental delays, an FASD assessment can be a recommendation. We then refer to neurological services who can assess children against the Australian Clinical Diagnostic Guidelines, which has rigorous testing of the 10 brain domains. And this will identify if a child has severe impairments and may or may not get a diagnosis of FASD. So they need to have 3 severe impairments, and they don't necessarily need to have the facial features. So just on this slide here, this is what the 10 brain domains are and what they assess against. So what can social workers do? Social workers can support parents and carers to understand by ensuring teachers, extended whānau, respite carers and any other service involved to attend the feedback session from the assessment. If all parties are on the same page, then we will have better insight and understanding for all involved. There is plenty of research around FASD that we can also share, and we even have FASD cards, and they're really helpful for carers on those very challenging days. They can look through the cards and find some solace in some of the struggles that they're experiencing. There's also support groups online, and I was involved back in about 2015 on the Gold Coast to open a private FASD Facebook support page, and now that has over 900 followers, including experts who add more research and local services there. So that really supports the whānau. And you know, I've also been in New Zealand helping families to join that group, because there's certainly a lot of information and support, and they can privately share their struggles with other people going through the same things. That can be really helpful. So when we're discussing prenatal alcohol exposure with parents or whānau, it is really important that we only ask the questions that we need to know. So when the neurological assessment, FASD assessment is done, they use what we call as an audit C checklist, and this is what this is. And it's just tracking the frequency and the volume of alcohol to look at a pattern and decide at what point is there a risk for FASD. And my next slide is around, I really run by a no shame or blame policy. We know that up to 50% of pregnancies are unplanned. Addictions can be challenging to address, particularly through pregnancy. There could be abusive partners that may pressure women to drink alcohol while they're pregnant. Research also tells us that women do not intentionally seek to harm their unborn child, and shaming women with words does not promote prevention efforts. Rather, it's not helpful for the mum at all, and we really want mums to seek out services and become engaged. So social workers can link local therapeutic services and interventions for children with FASD or brain domain impairment. So even if you get your assessment back and it doesn't necessarily have a diagnosis, it might still have severe impairment in a couple of brain domains. So it's really important that we know those services and we link them to the whānau. Sometimes in my workplace, we'll also fund these services until Ministry of Education or Ministry of Health increase their involvement. If children are old enough, we also explain to them the outcome of their assessment. Social workers may be a bit nervous explaining the diagnosis. However, you'll often find that the children are very accepting of the situation and express relief that they know that there's a reason behind their struggles. Children with FASD are all very different from each other, with individual challenging behaviours, and they need to be understood and not judged. If thorough case route intervention is completed in the very early years, there is a significant reduction in the likelihood of placement breakdowns, multiple placements, and attachment disorders. Sometimes in my work, we will fund these to we join the gaps and try and get this happening for the children as early as possible, and sometimes even before they start school. You will discover some clients have a reasonable cognitive score, so they can be misinterpreted as capable rather than but defiant. I often ask our staff if the client can't or won't. This challenges them to look past the cognitive capacity and wonder about memory, about executive functioning, about speech and communication, and social emotional regulation. In my experience, I believe this is where our FASD clients struggle the most. And I think back to when I worked in juvenile detention centres in Australia, and I know now that there was a lot of evidence of FASD with the clientele there. There is an urgency to address neurological and social impacts on children with FASD in New Zealand, as this is a public health issue. It has staggering economic costs to New Zealand. Whilst neurological assessments are expensive, they're approximately about 8,000 each at the moment, the lack of diagnosis actually has a more significant impact on our society. it is estimated that the cost of FASD in New Zealand is within the region of 49 to 200 million, not including the costs on education, health and justice systems, which could possibly bump it up to at least 800 million. And like Joanna said, you know, we're in 2022 now, so it could be a lot higher. There was a national action plan by the national government. However, the onus was on the social sector to address FASD issues internally and finance any costs on their already tight budgets. So social workers are also activists, and therefore by addressing the bigger picture of FASD in New Zealand, we can reduce the likelihood of preventable secondary disabilities such as mental health, poverty, suicide, unemployment, homelessness and addiction. I challenge local policymakers as to why we have alcohol in supermarkets. We didn't have that in Australia when I was living there. It's not a staple food. I also challenge why there's more bottle shops in towns where there is more poverty and unemployment. Why has New Zealand not completed an FASD prevalence study? Why has it taken so long for New Zealand to have the warning label on the back of alcohol bottles? We've seen the same bottle of Sauvignon Blanc to Europe, and it's had a much larger label for many, many years now. And the reason that we need to put the warnings out there is that New Zealand conservatively estimates around 3,000 children born each year with FASD. It's really high time that we had a prevalent study, and that there's preventative measures that are accessible nationwide. And these measures and this education could be funded by the millions of dollars in alcohol taxes that our government collects each year. So just a bit of food for thought for people. Thank you very much for my time, and I hope I've inspired you to know a bit more about FASD. Thank you.
Well, kia ora, and thank you, Karleen. Again, some great food for thought, I would say. And it's great to see in the chat panel, people are giving out lots of useful resources, information, where to get further ideas from. Hopefully, people are thinking about some questions they might want to ask the panel at the end of my little bit. But thank you so far for the contributions that we've got on the chat. So I'm now going to share my screen. Is that coming up okay? Great. Yep. Well, no mai hari mai ki te whare wanaga o Otago, so welcome to the University of Otago. Ko Dartmoor te moenga, ko X te awa, ko Anglo-Saxon toku iwi, ko Devonian toku hapu, ko Exeter Cathedral toku marae, no ingarangi aho, and gari keo te poti taku koinga, ko Anita Gibbs taku ingoa. So I'm from the UK, but with a bit of a Kiwi accent now, having been here for 23 years. And I work at the University of Otago as a criminologist and social worker. I remain a registered social worker, having worked, you know, in the field of justice and assorted NGOs during my time in the UK. And people know me quite well as also a caregiver activist, especially those of you in Australia, where I've been working with no FASD in particular in relation to online caregiver digital support groups. But let's think about social work and best practice. And just really in the short time that I've got, I want to highlight a few things which will just back up what my colleagues have shared. And that really we need social workers to be neuro-informed. We need them to be highly attuned to families. We need them to work in a culturally secure, safe way and space. And we need and want system-wide healthy outcomes. So I'm just going to put this on, make sure I've actually got the slide. There we go. Larger. There we go. Okay, so I mean, look, there's some excellent research literature, evidence literature emerging. I mean, a lot of it obviously from North America, but increasingly studies are being done in Australia, UK, and in New Zealand that are beginning to unpack what it is to be FASD informed or neuro-informed. But one of my favorites is the work of Rutman from Canada, and Deb Rutman. And she basically, in her work, reminds us that, you know, FASD is a brain-based disability. We need to understand that. If we're social workers or anybody working with families where FASD is an issue, we need to first and foremost understand the sort of physical primary brain impairment issue. But we also need deeper knowledge of disability and disability systems, and we need to understand things like the social model of disability. We need to understand, you know, neurodiversity, because we need to have a rights-based understanding of how to work with people. Because if we just think about FASD as a brain-based impairment, we're going to possibly have a deficit approach to working with people. So we really need to have a broader understanding that there are many discourses of disability. You know, different cultures define disability and experience disability different, and so forth. Within being FASD informed, we need to be person-centered, and I think that was highlighted very well by Karleen. We've got to listen to families and listen to the young person, young adult, child as much as we can, and then basically do anything we can to make their world and the environment around them an easier place to live. We've got to create safety. People have got to feel safe in your company if you're a worker, but they've got to feel safe in their home. They've got to feel safe at school. They've basically got to feel safe. And again, if we're neurotypical, our understanding of safety might be very different from what it is experienced by those living with FASD. So we need to find out, what is it for you? Does it look like to be in a safe space? Obviously, we'll talk about families in a minute, but we can't do anything if we don't have a family-centered way of working. We need to, and thank you for that slide, Karleen, talk about strengths-based, including language, but also obviously the positives, because sometimes the FASD world, those of you listening in from as caregivers, or those of my colleagues with no FASD, know that chaos can be a daily reality, absolute daily reality. So sometimes it's hard to find a positive, you know, way of viewing what today is going to look like. But we need to still work harder to find the positives, because we know our kiddies and young people have strengths. We need to implement really good strategies, and Karleen, actually, she forgot to wave her FASD cards.
Sorry.
Just one of those resources available in New Zealand, but essentially that pack of cards will say things like, hey, when you're working with somebody, be specific, be precise, keep it simple, and give visual reminders. So we need to know how to implement those really grunty strategies of support and help. Obviously, we need to model and coach. Again, workers forget to do that. It's easy sometimes, I think, to be with a young person and just say, okay, we're empowering you to have your choices and tell us what you want to do. But actually, where is the scaffolding? Where is the alongsiding? Where is the peer-to-peer support? Where is the real patience and time that it needs to take to teach a skill, reteach it, remind, go back to it, knowing what we know about the memory issues for people living with FASD. Always ask a person if they can understand. I mean, we think we do ask, but actually, I think often we don't. We think that the person is getting what we're saying. Actually, find out what they're getting, because they're probably only getting half of what, you know, articulate professionals and well-qualified professionals are saying to them. Thinking about caregivers, this is one of my absolute favorite slides, because and it's easy to access, and I've given the link there. There's plenty of links if you start researching. Being attuned to families, again, it sort of feels like that's taken for granted, but it's not that simple. Too many caregivers that I spend time with tell me that actually they have great difficulties communicating with social or support workers for their children. And what they really want social workers to know is kind of all of this stuff on this beautiful poster done by colleagues in Alberta. So it's the lifespan, the life course aspect to FASD. The children never grow out of it. We know that as caregivers, of course. They don't grow out of it. The challenges may change. the skill levels may change, the environments and stresses of those environments will change around a person. So it is a lifelong disability and we need to respond accordingly. But caregivers in all of these areas are asking for support, whether it's a few days respite here and there or a few hours sometimes, whether it's to get access to disability funding, whether it's to be on programs, to have more supports in schools. Of course, caregivers are going to be asking for this kind of wraparound support. And it's so hard to get, especially as we've highlighted, New Zealand officially does not recognise FASD as a fundable disability. Only if it's alongside autism or alongside an intellectual disability or other acceptable disability, shall we say. So it is a bane of our disability advocacy that every opportunity we make that point in the hope that it will change. So all of these things caregivers would say to social workers, say, could I have help with? And a lot of the times, of course, poor social workers will go, I don't have any funding. How can I get funding? I would love to help you. But it's a case of, hey, the more you know, the more you might be able to, be that sort of street level bureaucrat where you can get some resources, find out funding sources, irritate people, advocate and, scream and shout as best you can if you're a social worker. I know it's not easy because that's what social workers tell us when they don't have ready access to education or training or funded assessments or ongoing professional development. It's really frustrating. We understand the situation that we're faced with, I guess, in Aotearoa, and I guess also in Australia it's not too dissimilar in many ways. So the other, if you like, framework, I mean, there's lots of frameworks to understand, but the other point I was really wanted to make was this sort of idea of cultural safety and the need to essentially help people feel safe in their cultural space, whatever their background is. Now, obviously in New Zealand, we've got Māori, but we also have good proportions of Pacific people, and we have, other ethnicities. But in terms of the Treaty of Waitangi, Te Tiriti, there are certain principles and practices that are well known in social work, and actually social workers have to demonstrate their competency, able to be implementing some of these principles in their competencies. So the competencies, this is just one model from a resource that's on the last slide that you'll be able to access if you wish, that I wrote with a social work colleague a few years ago, looking at sort of youth justice space in particular, but actually asking the questions, what is it we need to do? Well, there are things that are obvious in terms of, yes, we need to screen and diagnose. Yes, we need to develop tailor-made, individualized, strength-based programs. Yes, we need to understand what FASD is and get our education right and deeper and more knowledgeable in terms of what social workers need to know. And yes, we need to work really well in a multi-agency context because that's what's going to work for our children and young people. But we need to have, core values and core processes that enable people to feel culturally safe. Clearly, we need to develop specific cultural models that work for Māori and by Māori. And there is some work in New Zealand going on where that is the case. But fundamentally, these concepts, te rangatiratanga, help us ensure a safe space and help us enhance the integrity of a person, believe in the potential of the person, show respect, and hospitality and no judgment. So that's what really that would be part of a process. The manaakitanga is offering, if you like, hospitality and as well as respect and kindness. It's really about believing in a person that they can flourish and do well if they're given the right supports. The whanaungatanga is actively pursuing quality, meaningful and sustainable relationships. And again, we all agree that good relationships, positive regard and good relationships form the basis of good quality practice with children and families. And yet, obviously, sometimes we find that incredibly difficult to actually do. So in terms of best practice, this is what, I mean, we all want to see our own FASD system of care or success, or, you know, evidence-based, wraparound supports. And we've got some good models around the globe, haven't we? I mean, I think Alberta is always a very strong example, although when I do go to Alberta, and I haven't been for years, unfortunately, we find that they say we haven't got enough money, and yet, of course, their systems are far more developed than ours. And I can see I'd glitched a wee bit there, but anyway. So the key worker system, we'd like to see more FASD navigators. I noticed my colleague Anna Gunderson, she's on today. She's a FASD navigator in Auckland for FASDCan. There are several in New Zealand, but we should have them in every region. You know, people who specialize in being able to support families and young people and those in the communities wanting to know more specifically about FASD. We need communities of practice, or FASD networks, where agencies are working together from a national strategy and infrastructure, and then regionally, in the same way that maybe things like a high and complex needs strategy or plan may work in a region. You want key agencies coming together to set FASD specific plans and money to support those plans to be implemented by a range of agencies in your community, whatever that community is. We don't have any FASD standards. Well, Alberta and some pockets of other parts of Canada have FASD standards for care of children. In other words, how much training should a social worker or care worker or foster caregiver have per year in FASD? When should a child be assessed for FASD, making sure they can be assessed for FASD, and other things that are happening for them. A whole range of standards that we have, care standards in both of our countries, but what does it look like if we did them specifically for FASD? It would be great to develop those. And then all manner of advocacy and mentoring services. Everywhere you look in Aotearoa, there's piecemeal things going on, great small, scale bottom-up approaches done by people with passion and champion qualities, but we just don't have that coordinated infrastructure. We need to see more funding given to organizations like FASDCan and NoFASD, so we can actually get more of that grunty caregiver training and support and individual support out there. And again, going back to Alberta, because I'm conscious my time will soon run out. This particular publication, again, there's the web link to access it, Towards Healthy Outcomes, with a range of authors who basically, have looked at all the evidence-based practice as well as the research studies. You could have a good read of that, because that's a life course approach to understanding how do we help families, individuals, communities, because obviously, as Karleen highlighted, it's about alcohol, and certainly Joanna showed us the stats in terms of the alcohol consumption. It's about that big picture. We can't talk about FASD if we don't talk about the big picture. We can't talk about FASD and social work if we don't have a big picture mentality. But at the same time, it's individuals, isn't it? It's people, their lives, their challenges, that need support in all of these areas, because we want to see them live the best life that they can live. So I would also sort of encourage people to look at resources that, are going to take a holistic view of a person and a family, so that, you're not just looking at, the mental health bit of a person, or the, the housing struggles of a person, or the parenting skills of a family. You're looking at everything, and you're looking at it with that prevention, all the way through, obviously, to intervention, to life beyond perhaps too many services, and interdependence for young people, perhaps, as they move through their lives and into older adulthood as well. So there's a lot going on. And obviously it's hard. I mean, social workers generally as a group of people do have an ecosystem sort of way of viewing the world, and then they find it frustrating in terms of their day-to-day work to actually get the resources and time that they need to do the work that they would love to do, because that's the other issue, just the sheer numbers of caseloads. The reality of the grantee co-face work means that social workers are not able to always work in the way that they want to, and actually have sometimes been trained to do with families. But we've all highlighted different things where we would like to see changes, and moving forward. We have moved forward a long way, perhaps in the last 5 or 6 years, but we've got a long way to go. We can't even have, as Joanna said at the beginning, we don't even have that prevalence study, and backed up by Karleen too. If we haven't got some basics, it can get incredibly frustrating. So that's just a list of a few references. Just to mention, of course, you've got in Australia, you've got your fabulous graduate certificate in the diagnosis and assessment of FASD, which Karleen has been doing. And in New Zealand, we've got just started this year, not due to run till early 2024 for the next one, but essentially we've got the certificate. It's a full semester course, and it explores neurodisability in health, welfare and justice systems. So it covers FASD alongside other neurodivergent conditions. So there are resources out there. If you want to find out more, you can do. So I will stop the share, because in terms of the time, we can then see what comments or questions we may have. What would be needed for a prevalence study in New Zealand to occur? Joanna, do you want to quickly answer that one?
It really comes down to funding. And again, I think it needs to be a sort of a multi sort of ministry coordinated approach as well, not just coming from the Ministry of Health, but the Ministry of Education, the Ministry of Justice, because we know that FASD, affects across the lifespan. And so just having Ministry of Health come forward to fund it, they won't, and it really needs to be a coordinated multi-minister. It just comes down to funding, really. And we have been pushing for a prevalence study for a long time. Yeah.
Cool. Okay. So as I'm just looking at the messages. Is there any pressure? There's a comment from Candice. If 50% the pregnancies are planned, is there any pressure on the government to legislate and criminalize parents whose children are FASD? I mean, there's been some cases in the USA, I think, where they've tried to kind of punish parents, for their drinking behavior. But I think New Zealand, generally speaking, would not even want to go there. And you see it in the courts sometimes, certainly in relation to mitigating or aggravating sentences. There have been cases, where FASD is used as a mitigating, which would be more appropriate in terms of explaining people's behavior. But sometimes it's been used in kind of like parole or bail conditions, where they say, well, they never learned, they fail to make the same mistakes over and over again, therefore they should be not released, because they'll continue to be who they are, which is also true, because people have a disability. They don't not have that disability if they're in prison one day and out the next. However, again, it's about one's attitudes around disability, and believing in rights, and believing in fairness, and believing in equity, and believing that at the end of the day, if people are born with this, why should they be punished continuously for this lifelong disability? It's just ridiculous.
And I do also want to add that, looking at our drinking culture, alcohol is a much bigger issue than just, blaming the parent or blaming the mother themselves. I mean, look at all the advertisement, and as Karleen was talking about, it took us over a decade just to get a warning label. And it's a big issue, and it's not just one that should just be the personal issue. It is an environmental one and a society one where I think everyone needs to work on it.
And there was one question: are there any studies on FASD mums who've had children of their own, or are they affected by their mother's FASD? In other words, is the FASD passed down? Look, basically, no, the FASD per se isn't passed down. And there are some good articles around where people have been parents with FASD, but you have to then ensure that it's supporting the family so that people can be the best parents to be able to. So there might need to be more accommodations, and I think a lot of the early pregnancy projects are about supporting mums where perhaps one child has already been born with a potential FASD but hasn't yet been diagnosed, and obviously a second child might be along the way, and how to prevent that child either having FASD as well as having a good 3 to 5 years best start in life. So there are definitely, well, in New Zealand they've got pilot programs, and of course Canada have done the PCAP work, which is really significant and important. Does anyone else want to, any of the other panelists, because I haven't been able to read all these.
Just from an educational perspective, I can see some of the comments around shaming and blaming. We do need a lot more education across New Zealand. There's other countries that will have on, primetime TV, and the adverts will have adverts around FASD for preventative measures. And this is exactly what our clinical network fights for, these types of things, and drives these types of preventative measures, so that there's a lot more awareness out there.
So is any more questions? Just giving you an opportunity for final Q&As, if you have any out there, or to give my panelists a last chance to say anything that they might have forgotten to say but wanted to.
There is a question there about lobby groups who petition local government for bylaws regarding zoning of alcohol shops. I think that's something that the whole 5 million, our team in New Zealand, does need to address. And if you do go into some places that I've lived and worked around, some towns have a lot more bottle shops, and then alcohol also in the supermarket. So certainly petitioning local government would be a really good strategy.
And then supporting initiatives like the Green Party, Chloe Swarbrick, who wants to see less marketing and less advertising in sport. Supporting those initiatives are very important when you see those chance to kind of like change maker, sign a form online to support those initiatives. But yeah, writing to your local MP can go a long way, because the more comments that they get, the more they're likely to go like, this is an issue, I need to follow up and understand more about it. Same with FASD though. If we want action on that, we need to be telling our local politicians about the impact of FASD on the community and on the professional workforce as well, because it is a big cost for everyone at times, where so, as I say, social workers can get really frustrated because they want to do more and they care deeply and they are learning, but they can't just say, I'll send you along to the FASD navigator if the FASD navigator does not exist, or I'll send you along to this FASD service that particularly supports 5 to 11-year-olds, and they do a FASD camp once a year. When it doesn't exist, they can't send them. So it is a case of advocating for services and supports. It's not just one agency's responsibility. It is an interagency response that's required to what's going on for people in the community.
And I agree completely with Anita, and it's not just for social workers. We're finding the same across our educators survey, our lawyers survey as well. A lot of them are wanting a lot more resources and training around FASD, and a lot of them only have sort of basic understanding, and I think it really points to we need the funding and resources to better support our workforce.
Okay, so we just did a final thing, requests for the slides, which we can make available via Elizabeth perhaps, or we'll find a way to make that happen, because or certainly in my case I can make mine available, so yeah, no problems there. Yeah. And the final comment from Mel was, yes, I would challenge the idea that drinking causes FASD being common knowledge. Yes, it's a privilege to be educated, I know. And it's interesting because obviously the surveys suggest that, that really people should know. But actually the reality is when you talk to people individually on a one-to-one basis, you go, they're a bit clueless, actually. They have this little idea about maybe, you know, something might affect the binge drinker, drinking 4 nights a week heavily drinker for the whole 9 months. But actually, the idea that it could be small amounts of alcohol impacting a child's brain is actually still quite a radical idea, it would seem.
Absolutely. And I think there's still the sometimes inconsistency from the messaging around, during, that you can still have one drink, that it's safe when you're pregnant, that, we still get that from some professionals. So I think the messaging around no safe level during pregnancy is really important. And we need to continue to advocate for that sort of messaging.
And then there's another one from Anna. I got told by whānau that they get told from the social workers and frontline staff there's no point in getting a diagnosis because there's no support out there for FASD. What's our response? Well, I've heard that too. I've heard it locally, and it's enduringly frustrating. And I can see Karleen's going like, woo, steam coming up, because of course a diagnosis is a pathway. It's a pathway to so many things: education, potential support, opportunity to use it to kind of stick under people's noses and say, hey, this says I need services, there's lots of challenges here for my kid, whatever it is. Diagnosis, and most families that we meet, okay, they're probably the if you like the keen ones, but they agree a diagnosis actually is necessary, even sometimes where there are clearly no services available. But you've got to get the prevalence, you've got to know what the issues are, you've got to be able to rule out other things, you've got to be able to say, hey, I want to rule out a genetic issue here, thank you very much, or is it FASD, or is it something else? So definitely people need to be given the choice, obviously, whether to go for assessment. I mean, that's important too, but yeah, getting a diagnosis to our mind is going to potentially lead to supports and services. Karleen, did you want to say anything?
I just want to say that it is social workers' duty of care to know the 10 brain domains and look out for them. There is really no excuse for not understanding that in the future. Not so much now. We need more courses through the universities for social work degrees, but we're getting there. Anita's started her one in New Zealand. I highly recommend the one I completed in Australia, but there will come a point in time that there will be no excuse for social workers to not understand the 10 brain domains.
Yeah, that's just like FASD basic, isn't it? But we still got to make that happen.
Yeah, we do.
Okay, well, I'm conscious of time, and I would like to say a closing karakia. This obviously is recorded, so some of you can watch this online. We'll try and work out a way to get the slides available. Thank you so much, everyone, for attending. Thank you so much, Joanna and Karleen, for this wonderful, fast-paced webinar that suddenly reached a conclusion. So I will close with a karakia. Kua mutu a mātou hui, mō tēnei wā mana kia tia, mai mātou o mātou hoa, o mātou whānau ao ki te orangi. Our meeting for this time, blessing upon us all, our friends, our families, peace to the universe. So thank you, everyone, and hope you have a good rest of day wherever you are. Ka kite.